Hello, welcome to this presentation of RXP International. In this presentation, we will be talking about an application of the psychobiosocial model to treating the seriously mentally ill. I am Dr. Elaine Levine, and I have with me Dr. Elaine Foster today, and together we hope to be able to enlist your assistance in working with this population from an integrated psychobiosocial model. There is no doubt that those with serious mental illness are a very vulnerable population. We will see that across the world, this population is particularly underserved, and very often the services that they do receive are inadequate. Speaking of the United States, we know that about 3.5% of the adult population has a serious mental disability that is preventing them from functioning within the mainstream society. And we believe that only about half of the individuals reported are receiving any treatment at all. When they do receive treatment, it's often very limited and bifurcated, where one person is providing medication management, someone else some psychosocial intervention, and the two are not well integrated. Now, the lack of adequate services occurs in the United States, but also around the world. And in some of our other presentations, we discuss the world situation in more detail. What I would like to mention here is that related to the lack of adequate services is a tendency to really stigmatize the seriously mentally ill. They're often seen as a series of symptoms rather than whole individuals with feelings and hopes and desires. And that orientation leads to a tendency to just treat the symptom and to assume that when the symptom, the hallucination, or the delusion has diminished, that the major goal has been achieved. Now, the major series of studies that addresses the problems of the seriously mentally ill is given the acronym PORT. There have been several series of these schizophrenic patient outcome research team reports. And the emphasis of these reports is that we should be working towards helping the seriously mentally ill develop a healthy and as close to possible normal, productive lifestyle. Before going further in this presentation, I would like to ask for some comments from Dr. Foster, because our earlier discussion with you of the importance of shifting responsibilities with mental health workers is particularly important in working with this population of severely mentally ill. Dr. Foster?
Thank you. I think that two things I'd like to pull out of the research by the World Health Organization that speaks to your discussion today. One is that because there is this shortage of mental health providers worldwide, a concept has been promoted of task shifting, which introduces the idea of empowering allied health professionals, particularly in the mental health field, to empower them to work with specific populations, and the most in need being the psychotic or seriously mentally ill. And what we would like to promote through these series of videos is the concept of enhancing the skill sets that are already had by the professionals who are in the front lines treating psychotic patients, but without the prescribing authority or perhaps even the knowledge that would help them to make better decisions for this particular population. And I think as you go through your presentation here today, we'll see not only how much there is a need for this type of approach to treating this population, but also step by step how you go about using the psychobiosocial model to the treatment.
Thank you, Dr. Foster. Now, I will be presenting a case to you from the position of a prescribing psychologist. And I know many of you participating in our program will not be able to prescribe medications, but as part of the team and shifting responsibilities more broadly to the team, I hope you'll see how the presentation here could have implications for you in your work in identifying the needs of the seriously mentally ill in terms of psychotherapy and medication management. Now, in another presentation, extensive presentation, Dr. Foster will be mentioning to you in detail, discussing in detail about issues involved with the seriously mentally ill. I would just like to touch on several issues as a reminder here that I think are particularly relevant to the case that I will be presenting. First of all, I want you to keep in mind that the mentally ill do die considerably earlier than the others in our populations. Why is that? Well, one reason is that the mentally ill are much more likely to have dual diagnoses and to also suffer diabetes. The reason for that is broad-based. They often have poor nutrition. They may be limited in their activity. Very often they're members of ethnic groups that have been marginalized and are less likely to receive services. The mentally ill, because of poor diet, often have weight problems. This can lead to gestational diabetes. And the lifetime prevalence then for diabetes among the severely mentally ill is 14%, whereas among the general population, it's about half that. Please keep in mind also what you've learned about some of the side effects of the antipsychotics. The metabolic syndrome can be triggered by antipsychotics. Dr. Foster discussed this with you in detail, but it's important for you to keep this factor in mind as the patient I will be discussing with you had several indices which were problematic in terms of his developing the metabolic syndrome. Also recall that there can be some long-term intractable side effects from antipsychotics, primarily tardive dyskinesia, which you have learned about, and that their risk factors for that include being elderly, female, having diabetes, having associated affective disorders, the length of exposure of the antipsychotic, and the degree of exposure, the amount of antipsychotic or antipsychotics prescribed, as well as certain ethnic groups being more sensitive to the tardive dyskinesia. I want you to think about this because, again, the patient we'll be looking at was vulnerable in this regard for several reasons. Antipsychotics can also cause the neuroleptic malignant syndrome. This is more evident earlier in the treatment, but it's something that is very important for you to keep in mind when you are doing therapy with this population. Now, despite these dangers with the antipsychotics, there's startling news for us to try to understand in our country. You know that the antipsychotics have been top-selling drugs in our country since about 2010. And the number of prescriptions have risen enormously in the last 5 to 7 years. And many of these are prescribed off-label, not just for people with severe mental illness, but many times children and the elderly, and they're being used as a means of sedating, or as Dr. Foster has discussed, almost as a straitjacket, right, Dr. Foster?
Mm-hmm. Chemical straitjacket.
Okay. Why is the psychobiosocial model to approaching this population so important? Well, first of all, it increases access to care to this population, but it's also a pathway for more integrated care, as you will see. Let me remind you of just a few of the basic aspects of the psychobiosocial model so that you can see how they apply in this case. You recall that the central thesis is that we look at the patient from their phenomenological viewpoint. What is important to them, what goals they want to achieve, what side effects are problematic to them. And even with this population, we will try to minimize the amount of medication so that the patient can access his or her own strengths. We still use least invasive, empirically tested approaches first, and we always use them in conjunction with the medication management. And we'll show you in this case how the use of the medication and therapy varies as you move through the deeper stages of intervention towards termination. Let me tell you about the case of Jorge. The facts here are basically true, though I have, of course, masked a few of the details to protect his identity. But Jorge very much wanted me to tell you about his case because he felt that a more broad-based intervention was very important to his improvement. He was a Black 19-year-old when I met him, and his family had moved from New York City to Las Cruces. They thought the life would be easier and it would be less expensive to live in Las Cruces, which I'm sure was true. Now, the parents came in with Jorge the first session, and a critical observation that I want to share with you is that they talked about him almost as if he wasn't there, though he was there, and spoke in place of him. and said that he'd had a very serious psychotic break when he was a teenager, and he'd been hospitalized at age 15, diagnosed as schizophrenic, and he'd been given 8 milligrams of risperidone and 15 milligrams of sertraline. This family was rather poor, and so he had not received consistent care since that initial hospitalization. A family doctor had continued his medication without any other kinds of intervention for a number of years until the family moved to New Mexico. At that time, and still the patient was just quietly listening, the parents explained that they found a psychiatrist, and the patient said, and the patient agreed with what the parents said, that he wasn't having any more symptoms. And so the psychiatrist had determined to decrease his medication. At that point, I turned to the patient and asked him what he thought about all of this, and he said, with very limited speech and without making any eye contact, that that was true, his parents were right, and that he was really doing fine. He just needed some medication to be watched, and he really didn't like coming in to see doctors. His paucity of speech was very observable, but he also had some extrapyramidal symptoms which were of concern and very noticeable. He shook his leg pretty much constantly. Sometimes when he talked, his tongue would like get in the way, and he would move his arm, and it was kind of graceful but very unusual movements. His parents were quick to say, when he was discussing with me his needs, see these movements? He does these odd things, and people are really frightened by him. So that was what I initially observed with Jorge, and I asked the parents to let Jorge and I have some time together to get to know one another. When I was able to talk with Jorge and then also look at his records, I was able to put together the following history. He was born as a fairly healthy child with an APGAR score of 8.6. His development appeared fairly normal originally. However, the mother discovered when he was about age 2 that the biological father had been physically abusing him. She came home from work one day and reported to me that there was blood all over the house, and when she confronted the father, he acknowledged shaking the baby, and that he'd been doing so off and on during these first 2 years of his life. The mother immediately divorced this man and had no relationship with him for a number of years. She then remarried an individual who had a daughter close in age to my patient Jorge, and the four of them became very close. Jorge particularly was close to his stepsister. I don't really know the details of that marriage, but I know that they divorced in about 4 years and moved from where they were living to New York, where the mother met her present husband. Now, even though Jorge was separated from his father that abused him, he did start having visits with his father again when he was about age 10 and indicated that he wanted to have those visits. But when he was a young teenager, his behavior began to change, and he became more quiet and uh, reclusive. And there was a period of time where he wouldn't eat, and the mother thought that if she sent him to visit with the father, maybe matters would improve. So she sent him there, but when he returned, he was floridly psychotic. He indicated that he had been captured by aliens and they had done horrible things to him. And he was mumbling and with making very little contact with his mother. So at that time, he was hospitalized. So my mental status examination revealed very flat affect, slow reaction time, as I've mentioned, impoverished speech. I conducted the Ames testing, which Dr. Foster has told you about, and documented some of the extrapyramidal side effects. I was also concerned, since he hadn't had any intervention for so many years, and because of his limited speech, to see if I could get a broader understanding about him. So he completed several personality tests for me, and also a short form neurological inventory. The results revealed that the standardized testing revealed that he was very suicidal, although he hadn't mentioned that to anyone, and extremely depressed. And the testing with the Luria, Nebraska neuropsych screening inventory suggested some mild neurological signs. So I referred him for further neuropsychological testing. I looked at his original blood tests, and you can see that there were problematic indications here of high cholesterol, and which can be a real indicator of the metabolic syndrome. So that was already of concern to me and got me thinking about what kind of medication should this young man be on? Did he need to be on an antipsychotic? Keeping in mind that the psychiatrist said he didn't think he needed to be on an antipsychotic, and also that my testing was suggesting pervasive depression. When I talked with the neuropsychologist, his interpretation of his testing was that the patient was not psychotic, but suffering from Asperger's syndrome. And he discussed with the patient discussed with the neuropsychologist that the only unusual symptom he felt he was having were these deja vu kinds of experiences where he thought he had been someplace before. The neuropsychologist felt that that could be a sign of some subliminal seizure disorder. So, with this information in mind, I worked on building a relationship with this young man. I asked him a lot of open-ended questions, and I had to wait a long time for him to be able to respond. I asked him what some of his goals might be and tried to be as supportive as I could in responding to him. He said that he would like to be able to go back to school, and he mentioned that his communication, it was very difficult for him to communicate. So we agreed together that a goal for our therapy might be practicing his talking skills. And that seemed to be very satisfying to him because it took the pressure off of feeling like he had to explain things to me eloquently and moved our goal back to let's just practice talking. My initial diagnosis in consultation with the neuropsychologist was major depression, Asperger's syndrome, an atypical psychotic reaction. By that, I meant that he clearly had had a psychotic break, but it didn't appear that he still had psychotic symptomology, and that he was a child of abuse. And I was looking to see if there were symptoms of PTSD that perhaps he hadn't yet been able to discuss because of his limited verbal ability. There were other biological axes to biological concerns to mention. I say axes because that was part of the DSM-4, but we're no longer talking about axes now. When I saw him and came up with these diagnosis, I was using the DSM-4. I think I didn't mention from a previous slide that he had also suffered a medical illness where he lost all the hair on his body. And this apparently was a genetic propensity in his family. His mother had also lost all her hair at one point in her life, but it had grown back. For him, the hair had not grown back. There was also extreme concerns about his getting appropriate help given the financial limitations of the family. So I'd like to stop here for a minute and ask Dr. Foster, do you have any thoughts or questions or anything that maybe needs clarification?
I was thinking as you were describing the case that looking at that psychosocial history and then that very important piece where you said that he wanted to talk after having been so nonverbal and unresponsive, having his parents speak for him speaks so much to this relationship building phase, because you asking to have some private time to hear from him directly and then him actually getting to the point of speaking to you freely, I think speaks to the model yet again, because rather than just say, okay, you have these symptoms and we need to medicate them, you're looking to uncover what is driving those symptoms. And I like the idea of having to still rule out PTSD, which can transiently produce psychotic symptoms. I think is an excellent hypothesis. And the other thing, as I think of alopecia, the first medication that comes to mind is valproate.
Right.
And so I thought, I wonder if he's on valproate, but I didn't hear it anywhere, so
No,
it was
he
just a trigger.
wasn't, but I was very concerned about that too and mentioned that to the mother. I wondered if he'd ever been on an antipsychotic that could have caused the hair loss.
Mm-hmm.
And that's when she told me there was this pattern within the family, but that most people, when they lost their hair, got it back, and he never did, which still made me wonder if there could have been some problem related to the antipsychotics. And I should mention too that this is a very handsome, strapping young man. But that was strange. He had no hair on his head, no eyebrows, and then these odd movements. You can imagine what it was like for him trying to function in the world especially with his limited language ability, and his parents already telling him that he was strange and he frightened people away.
And the other thing that I just want to highlight is, as we talk about the psychosocial model, we want to remember that looking at issues like medication for something unusual like alopecia would be one of the first things that you would consider. And we don't want to lose sight of that, because we are looking at enhancing the skills at prescribing in addition to the psychosocial aspects of the case.
Well, I'm glad you're bringing it up, because, the flat affect seemed like you often see in the severely mentally ill, even though he was saying he wasn't having any psychotic symptoms. But the psychiatrist had said he wasn't psychotic. The neuropsychologist had said Asperger's. And this certainly influenced what I did next, which was to try to continue getting him off the antipsychotic, because I was concerned about the high cholesterol. I still was concerned about the hair loss, and that maybe this was contributing to it. And I thought, we need to see if he can function without an antipsychotic. So I'm really glad that you brought that up. I think that's so important. And also, I might add, in this relationship building phase, what you were saying made me kind of go back to that time with him. It was so basic. I would wait till he looked at me for a second and then catch it and say, "That's wonderful. You've got beautiful eyes. I really enjoy getting to talk to you." So try to do just a lot of reinforcement and building from the very basic level that he was at.
And I'd like the students to remember the movements that you were describing, because if you haven't seen the video on the antipsychotics, you'll see that those are called choreiform or athetoid movements.
Right. Okay, so part of this initial stage then, as we've talked to you in the model, is to really think about what strengths does this person have? What are his vulnerabilities? How are we going to use his strengths to get around his vulnerabilities? Well, as I got to know my patient, it was evident that he was extremely well read. It was very halting, but it was amazing some of the conversations we would get into about philosophy or politics. And remember, my goal was just to help him learn to talk. So maybe on face, at the face, you would think, well, that's not therapy. But getting him to open up and finding ways to just acknowledge his intelligence and his thoughtfulness was very important. I also saw as a strength how much he trusted his parents. There was a real bond there. And even though we often say that the severely mentally ill have these negative symptoms where they can't put themselves in another person's place, he had a great capacity for empathy. For example, he would sometimes come in and say something like, "I'm worried about my mother. She just works all the time, and she's teaching school, and those kids are mean to her." And I thought, this is wonderful that he has got this ability to be empathic. And also, a strength was that we were developing a relationship, and he hadn't had a therapeutic relationship before. He was very artistic. He brought in some of his drawings. And what he did in all his alone time is draw and develop very sophisticated computer skills. Now, on the other side, I've never seen a person with low self-esteem. he once said to me he thought it was better that he stayed isolated because he wouldn't want to get close to a girl and subject her to his problems. It was just tragic how he put it. So the very low self-esteem was a vulnerability that we needed to work on. And clearly his odd looks were also, and the movements were a problem. Tried to address some of those in a practical way. I even talked to him about getting tattooed eyebrows, but he wouldn't go for that. But I knew that we needed to figure out a way to address the body movements, which were so unusual. The finances, the limited finances in the family, were clearly a problem, as you will see. And his fear of rejection, as I've mentioned, and by egocentric about being alone, is what I'm saying, that his self-esteem was so low that he kind of thought it was better for the world. His empathy worked in kind of against him. He was protecting the world by not getting out there. I was also concerned because you remember some of the characteristics we talked about earlier and that Dr. Foster's taught you about, who's vulnerable to tardive dyskinesia, that here's a young man, black young man, who also has already had serious extrapyramidal side effects for an extended period of time. So we moved through this initial phase, and I continued to reduce his risperidone, and I increased the sertraline. I'm thinking back, I'm not sure I told you the right dosage when I was speaking earlier. He started on 50, and I moved him up to 150 milligrams. And as he got more comfortable talking with me, in the active working phase, we developed a plan together to increase his social contacts and try to facilitate his independence. He helped develop that plan with me. He was going to the gym, as an example, at the university, and we talked about his beginning by smiling at one person. And then when he told me what that person was doing, we planned the next time for him to ask him something about the activity that he was doing. And this shaping social behavior seemed to be very helpful. In fact, the person asked him to go out to lunch after they had their workout one time. Now, this was a tragic side effect, problem here, was that he didn't have any money to go out to lunch. So he said he couldn't go. But at least he had someone that he was meeting with and talking with while he exercised. His mood did seem to be brighter, and stopping the risperidone stopped the movements, which was a great relief to him. And he became a little bit more self-confident. He even called someone on the phone that he had met in this online, on this class he was taking. It wasn't, it was just an evening non-traditional class, but he found somebody and he called him. He had quite a bit of trouble with the conversation, but that was a lot of reaching out. As I mentioned, his financial situation was a hindrance in our going forward. But then after 3 months, we seemed to go backwards. And I couldn't quite understand what was happening. And then the parents came in and told me that they had noticed he was stuffing a towel underneath the door at night to block out, we assume, any light or noise. And one time, when he was out of his room, they got on his computer secretively, and they discovered he was getting on a site all the time about people that said they had been abducted by someone from outer space. You remember that was the psychotic symptomology that he had had when he was younger, that he'd been abducted by aliens. And now he was back on a site talking with people that believed they had been abducted and saying that he had been abducted also. On top of that, both the parents and I had noticed more kind of inappropriate behavior, sort of like he was talking to himself or talking to a voice, and inappropriate laughing. Well, they wanted me to approach him about this and not tell him how they knew about this. And again, it's patient as object. So I had to really work with that patient, the parents, and say, look, if he's going to get better, we've got to treat him like a person and apologize to him in some respects for sneaking behind his back to look on the computer, and uh, let him know how concerned we are about him and why we did that, and that we want to get on the same page where we're all talking together. And they really didn't want to do that, but they reluctantly agreed to go forward with that kind of approach. Fortunately, he was very connected to them and a very sweet, forgiving guy.
Yeah.
So we brought him in, and they did say, we're sorry, we were concerned about you. Dr. Levine says we shouldn't have done it behind your back, but we did discover you were on these sites again, and we're worried. And he opened up about it. And what he's called these, he said he was having delusional memories. He described them as memories, not happening now, but that he was sure in the past he had been abducted. But the really surprising thing was that he said that they had never gone away, even when he was on a high dose of the antipsychotic medication. He always held on to these delusional memories. And this is something I really want to stress, because as I have worked more with this population, and I would like Dr. Foster's ideas on this too, I think this is often true, that the medication, the antipsychotic medication, is not really stopping completely the delusion or the hallucination, but what it is giving the patient enough time and kind of enough control over their minds to be able to say, that's a delusion or that's a hallucination, and to not act on it and perhaps not share it with others. Is that something you've seen too, Dr. Foster?
With my experience, it seems like there's this spectrum of response to the medication. So I've had some people who will clear up and look completely back to normal, but those are the rare cases. For the most part, you have either a decrease in the frequency of the hallucinations, and then, of course, what you're describing, which is the person is able to act at a kind of as a meta observer and say, well, this doesn't make sense. I had a patient who had something called capgras syndrome, which made me think about him because of your alien abduction scenario here. And he thought that his parents were substitutes and they weren't really his parents. he took the medication, and this is something I think you're alerting us to, is that the medication helped him guard his symptoms better. And so he was no longer telling us that he thought his
Exactly.
parents were aliens, but inside he knew they were aliens.
See, I feel that the more I've used our model and becomes sensitive to this issue, the more people I've realized that this is really what's happening.
Mhm.
And if you don't ask the right questions, they're just not going to tell you.
Or if you haven't done that relationship building
Right.
phase because you're seeing them for a few minutes and on to the next patient, they aren't going to tell you those secrets that they're harboring.
Now, I may be jumping ahead to the next slide, but it fits in so much with our discussion. When he started opening up like this, and he talked to me and said he'd always had these symptoms, but he didn't want to tell anybody because he was afraid that people would think he was dangerous, and he was afraid they would put him back in the hospital.
And
well, they would have,
Right.
It's very good reasoning on his part. So being sensitive to these issues and, having enough relationship for the trust for this to come out is so important. And you're going to see in this case that what Dr. Foster had a premonition about with his abuse, I don't think it ever would have come out if we hadn't reached this level of trust. Okay, so now we went on a roller coaster because it was obvious that he really did need an antipsychotic. It never totally fixed matters, but he couldn't control these delusions. He was getting more peculiar in some respects in his adjustment with this laughing to himself and trying to talk back to the voices um, as this, without any medication. So I wanted to try the medication olanzapine, which I know Dr. Foster has discussed with you, because there's less chance of his having these extrapyramidal side effects to olanzapine. And it did work well for him, but they couldn't afford it. So then we went through a period of switching around. We tried another medication that worked, but he was too sedated. We worked hard. We got his Medicaid, and then he was able to get back on the olanzapine, which worked really well for him. But then he gained weight, and you know why that would be a concern, right? Because we've talked about the metabolic syndrome. So then I thought, well, what else can we do? I tried to switch him to several of the third generation antipsychotics that are supposedly cause less weight gain. One just didn't work. He had extreme stomach distress. And then the second, Suprazidone, he had a rather strange reaction. He got very hypomanic with it. And so what we decided is to go back to the olanzapine, try to increase his physical activity, and keep as close a watch as we could on that weight gain, but that we were going to have to make that decision to that this was the best decision we could make in balancing out effects and side effects. I also decided to switch from the sertraline to fluoxetine because he still seemed so sedated. And in fact, that really did seem to improve matters. And we got a little better control over the weight problem with that combination. So he was treated with the olanzapine, 5 milligrams, 20 milligrams of fluoxetine. Now, an interesting thing came up. At this point, I got back in touch with the neuropsychologist. and told him, well, guess what? He really is psychotic. It isn't Asperger's. And what do you think? This is what I'm doing. And the neuropsychologist, who's also a prescribing psychologist, had recommended that I add in a little lamotrigine because he still wondered if there was some kind of subthreshold seizure uh, problem here that was contributing to some of the symptoms. So I followed his advice. Again, um, you can see the benefit of putting more than one mind to these difficult cases. And it really helped him significantly in stabilizing. And actually, his speech improved quite a bit. His ability to just have the words flow in a more comfortable fashion. Okay, but medication wasn't the only thing we're trying to do here in this working phase. I wanted him to learn more about his delusions since they were not really ever going away. We tried to test them in as many ways as we could think of. And the main way was he would describe them in details, what these aliens did to him. And by the way, it was like doing sexually inappropriate things with him, experimentation. And he would discuss it in some detail. And then I would say to him, okay, well, when did this happen? It happened last night. You really think all of that could have happened between 3 in the morning and 8 in the morning when you woke up? So we tried to test it with, a time orientation. And there were some other ways that we worked on it that were semi-helpful. But an interesting thing happened. He came in one day and he said, I've got it. And I said, you got it? And he said, I figured out why they were delusions. And I said, you did? And he said, they were all dressed exactly the same. And if they were real aliens, they wouldn't be dressed the same. Now, why that made sense to him, I'm not quite sure. But the process of asking him to test it helped him come up with something within him that was very helpful. He was thrilled that he discovered, finally, they are delusions. I can tell myself these are delusions, even though they come up. And it was a huge relief for him. We did other matters too along the way in this working phase. He really couldn't tolerate too much stress. That was becoming evidence. And the more he was sharing about when he had the symptoms, the more we understood that. So he'd been in school. Remember, he was very bright, but we realized we way needed to decrease the number of classes that he was taking. And we also worked in therapy and with the family to help him compartmentalize different goals. Because if he thought about everything he was trying to do, and by everything I mean get himself dressed, take care of the dogs at home, do his chores, do his homework, he just would get overwhelmed. He really couldn't tolerate a lot of stress. So we compartmentalize these. The first 2 hours you will do this, then you will look at your chores, and if you could just take it a bit at a time, he was much more successful. We did some CBT work, cognitive behavioral therapy work about self-esteem, changing some of his self-talk. And I worked quite a bit with the parents. This was ongoing, about not talking about him, talking to him, finding strengths. They're protective of him, but finding ways they could let him be a little bit more independent. And then, as he became more verbal, I did approach the subject of his trauma in his early life. And he knew that he'd been shaken, but he didn't really, of course, remember it. But whether it's what he'd been told about or if that was the trauma, or that there was some kind of primitive knowing. I don't know, but when we began to talk about this, you could see an emotional catharsis of sorts. And he talked too about his confusion of when to trust parent figures, because his father's biological father was still in his life and did still have a terrible temper, though he wasn't hurting him. And sorting out when parents care about you and what that means and was important. And a very delicate part of this, which we touched on a little bit, was his loving this person that had probably caused these severe problems that he was dealing with. And coming to terms with that was very delicate, but a crucial part of his getting better. So Jorge was better. He was able to go to school and be successful, though taking less courses than before. He had communication with his professor at school and several of the students. And I like to say he became more psychologically minded and medication minded. He understood much more about his own condition. He helped, even in this maintenance phase, to establish some new goals that would make him more independent from the therapy and more functional within his own life. He decided he wanted to learn to get himself up rather than have his parents get him up, which I thought was a wonderful idea. We worked on his making his own appointments to see me. Then we tackled transportation, and his parents went on with him on the bus several times, and he began taking the bus by himself to the appointments. He even took the bus to the shopping mall at one time. That didn't work too well the first time. He got pretty lost and had to call his parents. He got confused about what he was doing. It was just too much. But gradually, he even became effective at that. And he had a goal of gradually moving into some kind of transitional living facility where he could be more independent. So this idea that the world was better off when he was separated from him was beginning to dissipate. I thought you might find this interesting. Here are some differences in the results from July, when I first saw him, to August, and then finally April 2011. You can see that we were struggling with keeping his weight under control, but that we did seem to have some medication management that was helping us control his cholesterol level. So it wasn't perfect, but we had some control. Now, something I would like to encourage you to do, and that I've begun doing, which I think is very helpful, is to have some measure, almost weekly or by session, regarding outcome of how you're doing. Some measure by the patient and perhaps by others. So I have started using the outcome questionnaire 45, and I have my patients fill it out at the beginning of each session. In Jorge's case, he couldn't really fill out the form initially. His mother filled it out. But in time, he was able to fill it out. And at the end of my time of seeing him, he was able to fill it out. It's interesting to compare the results. The outcome questionnaire has 3 subtest scores and an overall test score. And we have his mother comparison before and after, and Jorge at the end. Initially, his mother saw him as having very significant subjective discomfort, and she still thought he was pretty uncomfortable when we finished therapy. But Jorge himself reported for him subjectively, he was much happier inside. In terms of interpersonal relationships, his mother thought he'd probably made more gain than he felt. So I think part of this might be his increased sensitivity and increased goals to relate more in the world. And in terms of social roles, still doing pretty well in the family and limited outside of the family setting. Overall, there was a pretty significant change in his adjustment. But we could also look at the behavioral changes. When I first started seeing him, he dropped out of school. Now he was taking some classes. He was achieving very good grades. Initially, he was feeling totally overwhelmed. Now he had changed to a major, art, that he could manage and was comfortable with it and comfortable with his professors. And importantly, he could see some of his own strengths. So Jorge and his family decided that they were going to move once again. This time to be near the mother's mother. And in this case, there was some very important work to do in the termination phase. First of all, I wanted him to recognize that he would probably need intervention over the long term. And he did, of course, understand that. We talked again about the importance of his finding someone he could trust, that he would really be able to share his symptoms with, because if he couldn't share them, there was going to be limited ability to help him. Since he'd become a lot more psychologically minded, we also talked about what are going to be the signs of relapse that you can recognize. And he was able to say, if I withdraw more, if I start becoming more secretive, if I can't remember these delusions are delusions. And I also wanted him to be more aware of the side effects of medications and be alert to them, such as the weight gain or any movements. So he would be sure and share those with the next treating people in his life. So in summary, I think you can see how we used a psychobiosocial model to help Jorge. And I think you can see the implications for you as mental health practitioner. You're the ones that will be spending a lot of time with the patient and establishing an individual relationship, understanding how the symptoms may fit into their past and their lives is so critical. And that information that you have can be a vital help to the person that is prescribing the psychotropics. And we know in many underserved areas, the person prescribing the psychotropics may not have the time to learn to understand the individual the way that you will, and that you will be the one that will be helping this person not just reduce their symptoms, but become a healthier individual, someone who can have a meaningful individual personal life. Dr. Foster, would you like to add some concluding comments?
Just actually, for the sake of the students and not knowing the case myself, I wonder, during the termination phase, are you no longer seeing him, and is his care being taken over by another professional?
Yes, in another state.
I
So
see.
I I don't really know what kind of care he received there because that person never asked for my records. So that's why I think it was extra important that I work with him and the family about what to look for in terms of his doing well, his medication, and future goals.
Excellent, because I can imagine, again, with this task shifting, that I could see very well how a mental health provider, knowing about the medications, may be seeing someone who then sees a psychiatrist every 3 months or so, but able to pick up on some of these symptoms that you've already addressed, and then having that trust that's been established so that they can not only trust that the patient will tell them when they're starting to maybe experience symptoms again, but then also to relay that information back to the prescriber.
Right. And that's why it was so important to me that Jorge understand how much progress we had made when he entrusted me with his innermost feelings, despite his fear that I might think he's dangerous or put him in the hospital. It was a scary thing to do, but that in doing that, he could get the help he needed. And for him to make sure that he found a provider when he moved that he could trust enough to have that level of openness. So, Dr. Foster, thank you very much for your help in understanding this case, and thank all of you for your participation.